Good evening, Dr. Derman. I'm going to give it just a few minutes to let a few viewers get on here and join us. How are you today?
I'm doing really well. Thanks for having me.
No, I want to extend a big thank you for joining me tonight to talk about endoscopic spine. As I jokingly said when we talked earlier, it probably helps that I'm a former patient of yours, a happy,
Well, you
successful
certainly have a
patient.
lot of you have certain insights into endoscopic spine surgery that I don't even have. So between the two of us, I think we've got the topic covered.
Yes, so we'll give it just like I said, just a minute here to maybe let a few people join. I'm doing it different tonight on LinkedIn. I'm actually streaming through YouTube for metrics and different reason to test, and I linked it on my page, so we may have a few people joining or actually watching the archival footage is probably what's going to happen. So as we see in the graphic, I'm being joined with Dr. Peter Derman. Dr. Derman's out in Dallas, Fort Worth. I'll take it right from his LinkedIn page. He's a MIS and endoscopic spine surgeon. Dr. Derman happened to be my spine surgeon, and want to talk with him tonight about how he got into endoscopic spine, maybe what amount of cases it takes to get to cruising altitude in endoscopic spine in his opinion, and where he sees endoscopic spine going forward and any exciting things that he has on his own menu. So I wanted to do something fun first. I wanted to show you and see if you could explain this situation here. This is a video I found. Can you tell us what's going on here?
Yeah, that was the old me. The new me is the skinny, pathetic spine surgeon. The old me was strong and used to be doing iron crosses on the rings. But yeah, I think about my life really in two phases. There was kind of the first phase, which was gymnastics, which was a huge part of my life. 17 years, started when I was 5 and all the way through college. I was the captain of the team at Stanford. That's what you were seeing there. And then the second phase of my life has been spine surgery. And there's actually a lot of overlap between the two. And I think that my experiences training and competing as a gymnast really prepared me and informed the way that I prepare and train for spine surgery.
So I probably have never told you this before, but really one of the main ways that I became your patient, and we'll discuss my case at the end of this, but one of the main reasons I became your patient is I'm a spine distributor or used to be in the Dallas Fort Worth area. And you and I had never crossed paths. I never had called on you, and I was down and out. And so not many people were hanging their shingle out that, hey, I'm an endoscopic spine surgeon, but you were. And again, I had heard about you, heard you were a solid dude, but didn't know you. And I Googled you, and I believe you were a 2 or 3 time All-American at Stanford, correct?
I
And
was.
that, and listen, most people only watch gymnastics in the U.S. at Olympic time, and we're
That's
inundated
right.
with the amount of dedication it takes. So I told myself, hometown boy does good, comes home, and he's saying he's an endoscopic spine surgeon, then he's an endoscopic spine surgeon. So, and then obviously we met and we're here now. So we realize, and we both discussed previously, the attention spans of doctors and med device people that may be watching this is short and sweet. So we want to get right to the good stuff here. People can watch this later. So I know you maybe have some slides prepared, but let's get off on what we talk about in the graphic. What was the pivotal moment or the watershed moment where you said, hey, I'm gonna dive into this endoscopic spine thing head first?
Yeah, I first started thinking about spinal endoscopy probably midway through my fellowship. So I did a minimally invasive heavy fellowship at Rush, where we did a lot of tubular type work, MIST lifts, things like that. And coming out, I was recruited and ultimately came back to Dallas, where I'm from, to work at Texas Back Institute as the MIS guy here. And there was always this lingering thought in my mind, what about this endoscopic thing? I wasn't exposed to it at all in my training, including in my fellowship. At Rush, at that time at least, there was no real full endoscopy going on. And so I started thinking in my fellowship, hey, I at least need to get myself exposed to this. Is it the real deal or not? I'm not really sure yet. I'm kind of cautiously optimistic. It seems cool, but I'd like to at least get my feet wet and think about doing this thing. And so, I finished my fellowship. I started practicing here in the Dallas Metroplex. And then what I ended up doing was going and doing one of the industry sponsored courses. So that was in August of 2019. I did my first course, went out for a weekend, did the cadaver thing, and the didactic part of the course, and then literally just read and watched everything you could imagine about endoscopic spine surgery. So ViewMedi, YouTube, I bought the textbooks and just kind of really gave myself a course in endoscopy and slowly started doing my own cases. So my first case was in November of 2019. So several months after my training course, and we'll talk about kind of how to get started, but I think it's a good idea to take a course in close proximity to your first case. And that case went smoothly. And, I started doing gradually more and more. My hospital acquired the endoscopic equipment in February of 2020. So a few months after that, we had it kind of on loan for the first few months to make sure that it's what I wanted to do and what the hospital wanted to do. And I just gradually increased my cases since then. Initially I was very, very selective on really cherry picking the perfect, easy starter endoscopic cases. So I think it took me like 4 months to do my first 10 cases, which is fine. It's good. When you're first starting, you want to hit home runs. Well, you always want to hit home runs, but you want to make sure you can hit those home runs early on. So it took me a while to get those first 10 cases under my belt, and then things rapidly accelerated as my comfort level increased. At this point, I'm doing well over 100 endoscopic cases a year, and that number continues to expand as I do more and more things endoscopically, whether that's cervical, which has become a huge part of my practice, or just more complex lumbar decompressions.
Yes, you can say too. Who was the company that you started out with that trained you from the ground up? Because I believe we have a mutual friend, Andrew Merkel, wanted me to mention him on here and say, hey, I used to call on Dr. Derman.
That's exactly right. So I took a Joymax course, and they did a really good job supporting me, both on the educational, from the educational front, as well as on a clinical front too. So, my first cases, they had someone there all the time from Joymax, making sure I was comfortable, making sure the staff was comfortable, etc. So that was the course that I took personally.
So, you were doing over 100 cases per year now. What is your bread and butter case that you're looking for, that when they come in and you look at the imaging that you're like, done deal, endoscopic case? And are you also doing endoscopic fusions?
Yeah, good question. So just thinking about tomorrow, I was just prepping for my cases tomorrow. I have three endoscopic cases tomorrow. Then I'm actually getting on a flight to Chile. There's an AO course I'm co-chairing. We're going to talk a lot about endoscopy, which is cool. But my cases tomorrow, I have a lumbar disc herniation. So it's a rare lumbar disc herniation now, wherever it is, that I don't approach endoscopically. That's kind of like the bread and butter chip shot stuff. So I have a lateral recess or a paracentral disc herniation. I have a foraminal disc herniation, and then I have a guy with foraminal stenosis. So stenosis is a little bit tougher. Bony stuff requires more drilling and is a little bit more nuanced. So those are usually more advanced cases. The other thing that I love doing right now are cervical cases. So endoscopic posterior cervical foraminotomy has got to be one of my favorite procedures of all, plus or minus discectomy. The ability to go in there, not disrupt all the muscle, not create all this posterior neck pain, which is associated with more open approaches, but still be able to access pathology in a way that doesn't require an implant. That's a real special thing. And so I love those cases. You asked about endoscopic fusion. I'm not personally doing endoscopic fusions right now. I mean, they're fun to do in a lab, but I don't think personally that the inner body technology is really quite there yet. I'm a big anterior column kind of guy. So if I have to do a fusion, an ALIF and a lateral are still kind of my workhorse procedures. And so to do a TLIF and put a really small cage in, I'm not really sure that's what I would want for myself yet. So, someday once there's massively expandable endoscopic TLIF cages, I think that will really change that decision making. And not to disparage anyone who's doing endoscopic, TLIFs right now. Clearly, we're moving the ball forward. But personally, in my practice, I'm using the endoscope for decompression procedures.
Right, and like you said, your gold standard case is an ALIF, and with the access, actually, that we have to great access surgeons in DFW, that is a luxury that other people in other parts of the country just simply don't have. So I like to hear that. For those that are watching, that might be reps or distributors that are new to spine or maybe intermediate. What would you be doing if you weren't doing endoscopic, the cervical posterior? What case would you be doing instead of that?
Yeah,
which would be more open and more.
You can do an open or tubular posterior cervical foraminotomy. The way I used to do them before I did it with the endoscope was through a Metrix tube. And it's still good surgery. The problem is it still results in a decent amount of neck pain, and patients get over it eventually. But you don't want them to have to struggle through that. And so what a lot of people have done is they've moved to the front of the neck, because from a surgical morbidity perspective, it's less painful for the patient. And what's less painful for the patient is less painful for the surgeon. And as a result, those patients who maybe are a candidate for an isolated decompression tend to get either a disc replacement or an ACDF.
So let's say you're at a training for brand new surgeons getting into endoscopic spine, or maybe even a company brings you on and says, hey, train our reps that are going to be out in the field so they know the vernacular and the lay of the land. Where does spondi and any type of column issues play into keeping you from being able to do an endo case, one of those layup cases that you referred to?
Yeah, great question. So the beauty of minimally invasive techniques, including endoscopic surgery, is that they tend to be midline sparing. And as a result, they don't tend to destabilize the spine. So in a patient who has spondylolisthesis or sliding of one bone on the other, if they have nerve compression causing neurologic symptoms, pain, numbness, tingling, weakness going down an arm if it's their neck or their leg, I guess we're talking about spondi, so mostly we're talking about their lumbar spine. Although I take that back. I did a cervical foraminotomy on a lady with a cervical spondi on last week, and she did great so far. But nonetheless, most likely in the lumbar spine. So if that spondylolisthesis is stable, then very frequently I can perform an isolated decompression, usually with the endoscope, to clean out the area around the nerves, whether that's in the foramen or the lateral recess or the central canal. And if you do a midline sparing technique and don't take a bunch of the facet joint, we have good studies to show that you do not destabilize that patient. And as a result, you can get good outcomes with that. Now, over the course of time, they may develop other problems, but your surgery is not necessarily causing that to be the case. And a lot of patients don't. So, the ability to just decompress somebody rather than fuse them is an ability to give them an easier recovery, and in some ways is protective to the levels above and potentially below, because once you start fusing people, there is the concern for adjacent segment breakdown. So basically, if the patient has a spondylolisthesis, but it's a stable spondylolisthesis, I'm still very comfortable just decompressing them in the vast majority of the cases. If it's unstable, so what are those patients? Patients whose spondylolisthesis moves based on their position, whether that's bending forward and back or laying down, or if they have, say, lytic spondylolisthesis, where they have pars fractures, that's inherently an unstable situation, then those cases, unfortunately, are frequently not candidates for an isolated decompression because their spondylolisthesis is unstable. And if that instability itself is contributing to the reason that they're having symptoms, then some sort of stabilization is often, not always, but often necessary.
So we talked about number of cases that you took to get comfortable. I'm just going out on a limb here. I'm guessing. I'm not a surgeon. The cervical region, you want to be really adept in the lumbar region, right? Before you move to cervical, is that the play?
Yeah, so if you look at the learning curve literature for the lumbar spine, it's usually somewhere in the realm of like 25 cases. And the key to that literature, if you kind of summarize it together, is that initially surgeons are slow, but they're safe and their surgeries are effective, which for me was extremely important, really from an ethical perspective, learning this once out in practice rather than as a trainee. So, I wasn't going to feel comfortable doing some sort of surgery that put my patients at risk. But instead, yeah, I was a little slow, but they still did really well. And that's supported by the literature. So that's really the lumbar spine. In the last year or so, Christoph Hofstetter and I published our own personal learning curves in the cervical spine. And what we found was a very similar set of findings, which is that early on, you're slower, but that's okay because your surgeries are just as safe and just as effective. Now, the interesting part, which comes back to your question, is our learning curves, his and mine, were somewhat different. Mine was actually a little bit shorter, so I got quicker, faster, and it took him a little bit longer to get more efficient in the cervical spine. And I think that the reason for that is I did far more lumbar cases before venturing into the cervical spine than he did. And so it's not like one of us is a better surgeon than the other, but I kind of got more comfortable with the mechanics of the scope and what I'm looking at and everything else before moving to the cervical spine, which kind of sped my learning curve and ability to adopt that in the neck.
Yeah, that's interesting. I'm assuming because there are still not many guys that are doing, not many surgeons rather, nationwide that are actually full blown endoscopic spine surgeons in the lumbar region. I'm assuming the subset for cervical, you go to the trainings and meetings, I'm assuming it's even in a more narrow group.
Exactly right. So, there's only a small number of us that are doing a lot of even lumbar cases. That's changing, and I think that's great for surgeons, for industry, for patients. And I'm optimistic that that trend will continue, that more and more people are going to pick it up. But there's a lot of people that do a little bit here and there in the lumbar spine. There's fewer of us that really do a lot of it. This is the majority of my practice. And part of that's because I practice in a unique environment. Texas Back Institute, we're 26 or so spine specialists. So we get to be really nerdy about whatever little corner of spine surgery excites us. And for me, that's minimally invasive and especially endoscopic stuff. And so, regardless of who the patient comes into, we just make sure they get to the perfect specialist for them. So my number one referral source is actually the other partners in my practice. And as a result, I get to see a huge volume of patients that have radiculopathy and things that are amenable to endoscopic type decompressions. So that's allowed me to get adept at it really quickly and do a lot of them because I just get my reps in. And then as a result, going into the cervical spine was an obvious next step. But as you said, there's not that many of us that do a ton of lumbar cases and therefore feel comfortable going into the cervical and thoracic spine.
Nice. Are you still the only endo guy there at TBI?
Yes. Some of my partners have done a few cases, um, but currently I'm the only one that does routine volume.
Nice. I know that you had a presentation. Maybe you wanted to show us maybe the timeline of how you got into endoscopic spine and where you're at now.
Yeah, I kind of had talked through this a little bit, but I can certainly share it with you. Sorry, my 3-year-old sounds like he's crying in the background.
That's
Um,
okay.
So this is just kind of a visual walkthrough of what I was mentioning, where spring 2018, I had kind of the idea like, hey, I need to check out this endoscopic thing. Finished my fellowship. Then in August of 2019, this is a picture of me at my first really the only endoscopic lab that I took as a trainee. That was that JoyMax lab. I went to Atlanta, Georgia, and did a lab there. And every day, it was a 2-day lab at that time, and they were like literally like trying to turn the lights off and usher me out, because I really wanted to get every second I could out of it, because that was my chance to really practice. This is a picture of me in my very first case. You can see I'm clutching everything so awkwardly like a caveman. This is part of the learning curve and how you get better gradually. That was in November of 2019. And here's me proudly standing by my tower that I got in February of 2020. And now, I'm doing 100 plus cases a year. It's not infrequent that I do 5 or so cases in a given day. And it's wonderful because these patients, they bounce back so quickly. They go home the same day. It's great for everyone all around.
Yeah. I appreciate you showing that slide, and you're right. We did talk through a lot of that. So it's very interesting to me. You're talking about the time being shaved down. I felt like, I had a 1-level discectomy done, and I felt like, what I was in there, you think operatively, 45 minutes, maybe start to finish, skin to skin.
Probably so. Yeah. Probably so. On average, I quote my patients, it takes about an hour per level. There's 2 things happening. One is I'm getting even now faster and more efficient and things like that, but I'm also tackling harder and harder pathology. So that hour time on average has been about stable. But the easy chip shot discectomies now take me substantially less time. So, half that or so. And really difficult cases could take longer, but it's not a race. That's what I tell my patients, and, doing it the right way so that they can bounce back quickly and have the rest of their lives in front of them. That's the most important thing.
Is there I thought I would ask you this, is there an endoscopic spine surgeon out there that's a colleague that you lean on from time to time, somebody you bounce ideas off of? Like, hey, I have a really interesting pathology on this case. I want to try it endoscopically.
Absolutely. Yeah. So we actually have we're calling the Endoscopic Spine Research Group that was founded a year or 2 ago. Christoph Hofstetter, who I mentioned before, was kind of the impetus for it. And he's gotten together about a dozen of us from around the country that do a lot of endoscopic surgery. And we've been sharing our data and publishing together. And even in the first year or so, I'm really proud. We've got quite a number of publications out, and many, many more to come, where we're really demonstrating the value of these endoscopic techniques. And the nice thing about this group is that we are all very collaborative, both from a research perspective, but also on a clinical side. So we have like a WhatsApp chat where we throw cases out and say, hey guys, what would you do about this? What would you do with this? Look at this cool thing I did. This is how I did it. And it's a really nice way to get like 12-second opinions immediately from kind of the movers and shakers in endoscopy.
That's awesome. And I figured as much. I know you like to collaborate in other areas of spine too. What is the coolest thing that, I know you're dialed in with probably various surgeons and companies behind the scenes, what's being developed. What is something that maybe you see being the coolest thing that's endoscopically associated that we may see in the next couple of years, minus a bigger footprint for a cage? And we're always trying to get bigger footprint in through a smaller incision. Harkens back to my Nuvasive XLIF days. So anything that you think's in the hopper technologically that guys are going to be doing endoscopically coming up?
Well, I think that there are a few needs. So like, what are the unmet needs in endoscopy? So one of those things is more efficient ways to remove bone. And especially in uniportal endoscopy, one of the bottlenecks for addressing severe stenosis and even in some ways doing bony work, if fusion is being performed, is bone removal. And bone removal still remains a little bit on the slower side. We could talk uniportal versus biportal and the pros and cons. Uniportal, in my opinion, is still the least invasive means of doing spine surgery. Biportal does allow you to use a bit of a more efficient drill. So for bony stenosis cases might be a little faster. But, I think that a uniportal drill that, removes bone more efficiently will be very, very important and will speed and allow us to do things that we can't otherwise do as efficiently right now. So that's on my wish list, a drill that works better. The other thing, as you said, was a bigger footprint cage. Everybody wants that. That would be wonderful. I'm sure it will happen eventually. I don't personally know of anything in the hopper that is dramatically different than what we have out there. And then the other category of unmet needs are things that will make the learning curve easier to mount. And so, endoscopy is awesome. There's no doubt about it. If I had, stenosis, disc herniation, and I needed surgery, I would want it done endoscopically. And I think that there's a lot of surgeons that feel the same way, but don't have access to endoscopic equipment and don't feel comfortable with the procedure themselves. And so anything that makes it easier to adopt will be important. So, I have heard of some artificial intelligence technology, whether that's coupling it with navigation and robotics might help as far as where people are in orientation. Those type of things will, I think, be important for getting kind of the more generalist spine surgeons involved with endoscopy.
That's interesting. I've seen someone else discussing potentially marrying robotics with endoscopic cases. The only thing I can think of in a world where we're trying to decrease cost, hospitals are like, hey, you've got the tower, you've got this or that. And this is a conversation for another time, but you brought it up. You're an orthopedic guy. I did a segment, a piece on the dual portal system with Amplify, I think I shared that with you. I talked to the CEO. Very, very interesting guy. He makes some really good arguments, but he's also a fan of uniportal. And I'm going to do a piece like this with him sometime, but it is interesting you brought that up. We've been on for 30 minutes and we promised that we were going to be short and sweet this time around. And I think we were going to discuss my particular case. So if you want to do that now, I know you have some slides.
Yeah, for sure. And let me share my screen real quick And you can talk through this as well. What I took is basically a very nice post that you made on LinkedIn after the fact, kind of describing the situation, which is that you had this horrible pain going down your right leg, and I'll let you talk about that. But basically, I pulled up your MRI here over on the left, and so, just to get people oriented who may not read MRIs a lot. So this panel up here is you from the side, belly, back, gray boxes are the vertebral bodies, the bones of the spine, and the discs are the spaces in between. And what you can see at this bottom level, and we're kind of off to the right side, is some of this disc had broken off and had lodged itself right where your S1 nerve is supposed to be. And that's the traditional sciatica type nerve that runs down the back of your thigh, back of your calf. And pressure there can cause pain, numbness, tingling, and even weakness in the leg. And then this is an axial view, kind of cut through this purple line here. And you can see this kind of blob right here, for lack of a better term, is that piece of disc that had broken off and was really occupying the space where your nerve wanted to be. But feel free to lend some color to as the guy who was experiencing this.
So I had gone to Mexico with my family on vacation in 2020, and it lifted my daughter up and felt something pop in my back, and then I came back and I was hitting into my golf net, and then I just went to my knees. And in a matter of a couple days, I was bedridden. I couldn't put any weight on that right leg. Could barely stand to shower more than 5-10 minutes or so. It was bad. I lost 30 or 40 pounds. I think it was probably 6 weeks or so from the time I had it until I was being operated on, and I had to seek you out over LinkedIn because we had never met. And that was about a 9 millimeter herniation. And I knew that I was going to qualify for endoscopic surgery just based on my experience as a distributor. And so I actually went through a pain doctor to get a really quick MRI. And I believe I sent this to you and said, hey, when can we schedule? And you were like, hey,
Yeah.
actually, this is a cookie cutter case for me. And then we had to do the song and dance about being able to get in and get it approved because cases were still very limited. But it was a really life-changing thing for me because having worked in spine surgery for so many years, a lot of times we walk into the room and we don't think about the person laying there is like gone through a lot, what their family's gone through, external circumstances, especially from a rep standpoint. And suddenly I thought, I don't wish this on my worst enemy. And so I went in and you said, hey, I'm going to fix you up. And my wife pushed me in, and literally I was pushed in a wheelchair. And a few hours later, I walked out and kind of halfway jogged, to the car just to test it. And, this is not a Dr. Derman infomercial. This is not an advertisement where I'm embellishing it. It is literally a true story, and I even put it in this LinkedIn post, and it was so dramatic and unbelievable that I told myself that, hey, when I have a voice and I get back into doing the video production, we are going to discuss endoscopic spine surgery, and so here we are. So
And here I'll show a little action shot of the offender, if you will. So this is you. This is your S1 nerve. We're on the right side. So your head is over here and your feet are over here. And this was that disc herniation that was just hanging out there, taking up space for the nerve. So I was able to, very safely get down, and you see that thing just kind of, it's like delivering a baby. That giant thing just came all the way out. And
that came all the way out in one chunk, huh?
It did, and it's bigger than the actual diameter of the tube, but the disc material is kind of rubbery, so it kind of squeezes through, and that's the little incision that you had. And this is, as you said, you felt so much better, which is so rewarding. And you even did a little piece for the hospital in one of the local magazines with your, looking great with your wonderful family. If people are curious, by the way, I've posted some videos on YouTube, full-length cases, both an endoscopic posterior cervical foraminotomy and a lumbar discectomy. If they're curious about what those cases look like or learning how to do them, I kind of walk through them, and these are kind of my social media links. And I talk a lot about endoscopy and spine conditions and spine surgery, et cetera.
Good stuff. Yes, you made me magazine famous. That magazine editor called me and said, "Hey, you speak the vernacular for spine surgery." He says, and you want to be in the magazine. I said, anything for Dr. Derman, absolutely. And again, I appreciate you. And you don't realize until you've had surgery. I mean, I was so limited. I couldn't even walk around the house, and I had missed a couple of my daughter's t-ball games, which is really foreign territory for me. And so I knew it was needed to be fixed, and it was dramatic. So again, thank you very much. And we've been on about, we're 36 minutes in. So I wanted to give you a few of my thoughts about where I see endoscopy going, where it's been and where it's going. And I've noticed that, I did a big piece on it. It actually got a ton of impressions on LinkedIn about Arthrex entering the endoscopic space. And so one of the things that I think that has kept a lot of surgeons and frankly distributors from selling endoscopic, a lot of it has to do with monetary reasons. I mean, those systems aren't cheap, as you know, but the reimbursement is also, it's not necessarily just the amount of reimbursement, it's reimbursement in general. It's been very hard to make that happen. And I know you guys have figured out ways and It's looking better. But I think that a major player like Arthrex getting in and shaking up the space is very intriguing. And to me personally, from someone who's looking at the industry from a rep mindset or distributor mindset, I see a Joy Max or maybe an Eloquence, someone getting bought out, brought into the fold of an existing orthopedic company. Now, you probably don't care or get involved in all those things, but it's good for endoscopic spine, the more money and the R&D that these companies pour in. Arthrex being in the space, I hear from people behind the scenes, that said, hey, this is not a PR campaign. This is a serious entry into the spine market. I mean, I did a piece where they had 100 spine surgeons show up. Joy Max to me, when I think, because you use Joy Max on me, I think Joy Max to me is the gold standard for endoscopic spine. That's not something you and I have discussed. That's just what I think the optics look like. I don't know that that'll remain the same. Maybe Joy Max wants to be bought out or partner with someone. But I think we're going to see a thirst. We're already seeing a thirst by other surgeons, because it's kind of like this. If you hang your shingle out that you were doing X-lift back in the day, a lot of the other surgeons will not get trained on that particular procedure until it's affecting them. And then you see kind of a leveling out of the playing field. And so I feel like I'm seeing some other guys in the DFW area pop up that they're endoscopic spine surgeons. So, I mean, what's your take on it becoming more saturated? I mean, the more the merrier. Is that kind of your mindset? Because ultimately it's about the patients, right? And think about it. I didn't have to have an ALIF at 45, which an ALIF or a big invasive case, because I would have had whatever you told me I needed just to get rid of that pain at that moment. And
Yeah. You bring up a lot of good points. So, I think that more competition is better in every respect. So from an industry perspective, I think Arthrex coming onto the scene, they have a lot of know-how as far as scoping goes for decades, and can bring a lot of that to spinal endoscopy. So we're not reinventing the wheel. I've had some conversations with Arthrex, and they're very motivated to create a comprehensive endoscopic spine surgery platform and innovate in this space. So I think it's great that they're coming into spine as well. And we'll see if other companies do the same thing. As far as, other surgeons adopting it, I also think it's great. Competition's great. It pushes us all to be better, as long as it's pushing us to do the better thing for our patients. One of my mentors from training used to say, hey, if you come back here and I'm doing the same thing in 5 years as I'm doing right now, then I'm a failure. And I feel the same way. I'm going to continue to push to do kind of newer and better and greater things for our patients. And as long as you do it in a safe and measured way, then that's the right thing to do.
I like to hear that. I feel this is, endoscopic spine is one of those watershed moments in spine. When I think back in my history, kyphoplasty was a big deal. XLIF was a big deal. One of those industry shaking moments. Endoscopic spine. I mean, when I saw that Arthrex had 100 surgeons show up, I said, this is getting serious here. And nothing against the smaller companies, but Arthrex has the breadth, that they have the cadre of people, and the facilities are amazing. And it's interesting to see, like you said, where it goes. And I think they'll be a company, I'm just guessing, that will look to make that endoscopic implant footprint bigger somehow. And I believe they'll probably get it done. So that's just a theory. I don't even know anyone at Arthrex, but are there any final thoughts that you have here? I think what I'll say is, I'm going to try to have you on maybe, if we can, once a month. I think the next time we do this, we'll approach it from like, hey, this is a specific patient. These are the initial images. This is the course of action. And then we can actually have, because I know you're really good at capturing video in surgery. And so you can get a case and we can get on here and break it down and actually have live interaction. Like, how did you do this or that? Because I'm just guessing that your first couple of cases, looking at the anatomy through a scope is especially for neurosurgeons. So it's a whole new thing, right?
So my first ever case, it was a chip shot paracentral disc herniation at L5S1. Similar pathology to what you had, but much smaller. Like, this would be kind of my cruise case on a day now. And it took me 3.5 hours, and that's okay. She did well. She felt better. Nothing bad happened at any point. But, I distinctly remember spending 45 minutes during that case looking at a tubular structure and thinking, is this the nerve? I'm not sure. Is this the nerve? What should I do? It turns out it was just an epidural vein. And so, like, very quickly, you learn, like, this is what things look like. And that's part of the reason why you're slow when you first start, but also part of the reason why you rapidly get more efficient and faster.
I think that's very cool. You mean you were actually able to, for lack of a better term, play around in there with an actual patient and figure out some of the anatomical landmarks that you're normally not seeing that way. So it was a win-win, because how many cases do you think total that you have under your belt now, endoscopically?
Um, Approaching 500.
That's pretty. That's a lot. I mean, you've
Yeah.
how many of those are cervical? Are you at 50 yet on those?
Yeah, I'm probably between 50 and 100 cervical cases. And again, that number is just like, both of those numbers are rapidly going up over time. So,
Well, that's awesome. I appreciate your time, and I think we're a little bit different than a lot of webinars. Like I said, we want to get in and out. So I promise you, anytime that you come on with me, we talked about this, as long as we hit that 30-minute threshold, everything after that's gravy and we can get off. We both have children running around. I have a daughter off the screen that's 8 and 9. And I heard your child screaming and crying. And so that's what happens around here all the time. And most of our viewers are in the same boat. Again, to reiterate, you are always a class act, especially for taking your time out here on a burgeoning, just getting started endoscopic spine webinar. I'm going to try to do this, once every 2 weeks, so twice a month, and really help spread the gospel. Again, I don't sell this stuff. It is more because it affected me so majorly in my life, that I want other surgeons like you to learn this so they can spread the gospel and spread the wealth for patients that don't need a really big invasive procedure. And I see the market trending there. There's a lot of interesting things going on, and I do look forward to hearing back from you again.
yes, sir. Well, thanks for having me, and it's always a pleasure hanging out.
Thank you. Have a good evening.
You too.